Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the Commonwealth Fund on integrating behavioral health within Medicaid accountable care organizations, emerging strategies. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's presentation. There will be 2 question and answer sessions held during the event. You may submit a question online anytime by clicking the Q&A icon located in the drop-down menu of the toolbar at the top of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the event, we ask that you complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope you'll take a moment to do this. I will now turn the webinar over to Deborah Brown-Kozik, Senior Program Officer at the Center for Healthcare Strategies.
Thanks, Travis. Good afternoon, everyone, and thank you for joining us. So today we will be highlighting considerations for behavioral health service and provider integration within Medicaid accountable care organizations, or ACOs, which is a topic that has gained momentum recently with the growing state interest in enhancing Medicaid ACO programs and the growing awareness nationally of the potential for these ACOs to improve healthcare quality and control rising costs. Given the prevalence of behavioral health conditions, particularly for complex high-need Medicaid beneficiaries, and the related cost implications, coordinating behavioral health services within Medicaid ACOs has been a noticeable trend that states are pursuing to improve quality of care and achieve savings. So during today's webinar, which has been made possible with generous support from the Commonwealth Fund, we will provide a brief overview of opportunities and challenges around the integration of these services and providers within Medicaid ACOs based on our work with states to date. We will then have Tara Suter, Director of Payment Reform from the Department of Vermont Health Access, who will provide an overview of the phased approach that Vermont has taken within its Medicaid Shared Savings Program to encourage this integration. And we'll also hear from Matthew Spahn, Policy Specialist from the Minnesota Department of Human Services, who will speak to the state's ongoing successes with its evolving integrated health partnerships. And finally, for the provider perspective, we also have on Mary Fisher, Executive Director of Southern Prairie Community Care, which is one of Minnesota's IHPs, or Integrated Health Partnerships, who will speak to the ongoing integration efforts on the ground among the providers in their 12-county rural ACO model. And we will then facilitate a discussion with questions from you all. So before we turn it over to our state speakers, I would like to introduce Pamela Riley, Assistant Vice President of Delivery System Reform with the Commonwealth Fund, who will provide some introductory remarks and lend the Fund's perspective on the importance of this integration work within emerging Medicaid ACO programs nationwide. So Pam?
Thank you, Deborah, and welcome everyone. Thank you for participating in the webinar. As you know, accountable care organizations are spreading nationally and gaining popularity as a model of paying for and delivering care that holds providers accountable for cost, quality, and health outcomes for a particular patient population. And we are now seeing more and more ACO activity in state Medicaid programs. At the Commonwealth Fund, we have decided to focus on supporting the development of ACOs in Medicaid as a model which we see as having tremendous potential, not only to improve care for a population that has a lot of complex needs, but also as an opportunity to incorporate other services needed by Medicaid beneficiaries, such as behavioral health, into payment and delivery models which can allow for more comprehensive care and better meet the needs of these populations. So there's a tremendous need as well as a tremendous opportunity at this time to integrate behavioral health and physical health in Medicaid, and many states are definitely recognizing that opportunity and using ACOs as a vehicle to achieve that goal. In terms of the opportunity, we know that Medicaid expansion is bringing about a fundamental shift in how behavioral health services are financed for low-income populations. We know that millions of low-income Americans will now have coverage for behavioral health services for the first time, and thanks to mental health parity, we'll also have coverage that is comparable to coverage for physical health services. We also know that there's a tremendous need among this population for behavioral health services. Medicaid expansion will result in millions of newly insured patients, many of whom have behavioral health needs or comorbid physical and behavioral health conditions entering the healthcare system for the first time. So there will be a new opportunity for Medicaid ACOs to transform the way we deliver care. We know that patients with chronic conditions, with both chronic conditions and mental health needs, cost more than patients with a chronic condition alone. And for Medicaid beneficiaries for chronic conditions, for example, we know that healthcare costs are 75% higher for those with mental illness compared to those without. So there's really an imperative to look at integrating behavioral health as a means of containing costs for this population as well. We also know that programs that do integrate addressing behavioral health and healthcare can substantially improve overall health outcomes and as well as the experience of care for patients compared to treating chronic medical condition alone. Despite being aware of all these benefits, we know that there are tremendous challenges that need to be overcome to integrating behavioral health and physical health care. We know that care systems are currently extremely fragmented, and there are numerous challenges in terms of payment, regulatory challenges, financing challenges, as well as administrative issues, both at the state level and at the provider level, which inhibit being able to better integrate and coordinate care. So we really want to focus on how to maximize the potential of ACOs as one means of overcoming some of these challenges to more integrated care for Medicaid beneficiaries. So we have supported CHCS over the past several years to work with several states to address some of these issues in order to further the overall development of ACOs in their Medicaid programs. And we have focused in particular on how to use ACOs as a vehicle to better integrate behavioral health. So on today's webinar, we hope to share with you some of the lessons learned from some of the states that have been more actively working on establishing Medicaid ACOs, and particularly focused on how they've begun to incorporate behavioral health services as a critical part of meeting the needs of their Medicaid beneficiaries through the ACO model. So thank you very much to CHCS and to all of you for participating.
Great. Thanks, Pam. So with that, just by way of background, for those of you who are not familiar with the Center for Healthcare Strategies, we are a nonprofit health policy resource organization based in New Jersey, and we work nationally towards supporting delivery system and payment reform efforts, and as well as quality improvement efforts aimed at enhancing care for publicly financed recipients, specifically Medicaid. We've had the privilege of working with many of you in your home states, and we look forward to many more years of collaboration together. So just to give a little bit more background in terms of CHCS's involvement in this particular area, I wanted to briefly highlight some of the Medicaid ACO-related initiatives that we've been working on recently, including, as Pam mentioned, with support from the Commonwealth Fund, CHCS has been leading a Medicaid ACO learning collaborative, which is now in its third phase, and we've been working with groups of states to help launch and or enhance their Medicaid ACO programs. So we just had our kickoff webinar for this next group of participating states listed here, and we're excited to see the accomplishments for this year's worth of work. Additionally, and on a related note, we are also supporting the technical assistance for participating state innovation model awardees as a contractor through CMS's Innovation Center, and as such have been part of several discussions and development of resources, some of which have touched around this notion of behavioral health integration and within the context of ACOs, and more importantly also how to align all of this work with other concurrent initiatives both at the state and provider level alongside various multi-stakeholder reform efforts, including PCMH, health homes, episodes, et cetera. Additionally, CHCS has also been partnering with Rutgers Center for State Health Policy, and we've recently developed a resource for prospective New Jersey ACOs to help them plan for their participation in the state's ACO program. We've also partnered with Camden Coalition of Healthcare Providers to help spread Camden's data-driven superutilizer model to a number of communities. And in thinking about these issues more broadly and considering the expansion of this approach in terms of integration to even a broader set of services, including social services, CHS has also actually coined the term of TACOs, which you may have heard of, which we've referred to as the Totally Accountable Care Organizations, which is really an aspirational vision for entities where all physical health, behavioral health, and social services are integrated for targeted high-need populations and supported through aligned financial incentives that promote shared accountability. So given all of this experience, we also wanted to highlight briefly some of the opportunities and challenges, as Pam referred to, that I think are important as context for this discussion. And so, as we noted, obviously there's growing recognition of the impact of behavioral health comorbidities on healthcare costs and utilization, and that there are significant behavioral health needs, particularly among the newly insured Medicaid population. And so there's an even greater interest among states, health plans, providers to integrate these services and using Medicaid ACOs as a vehicle to do that. And so in our ACO-related project work, we have touched on some approaches that states have begun to take to incorporate these services by way of potentially defining specific ACO requirements around governance, looking at sort of a phased approach for how to build out a scope of services that are accountable services within the ACOs, and layering various levels of services on existing primary care medical services over time. And so we've discussed how existing initiatives can also serve as building blocks and really be leveraged to further integrate the delivery of primary care and behavioral health and substance abuse services, including health homes. And so what we've heard and sort of what's consistently emerged is really the challenge, particularly at the state level, to incentivize behavioral health providers to really come to the table and want to do this work in what may seem to be more of a medically driven model in the term of the ACO model. So I think where we've started to hear discussions nationally are really about how to support and enhance the capacity of these behavioral health providers to participate in this transformational work at a practice level, and just understanding that process takes time and requires resources, and really, sort of comparing notes across the board about how to promote this notion of shared accountability that's being driven on the care delivery side, and thinking about how to support that from a payment side in terms of payment mechanisms that align incentives across stakeholders. And finally, just thinking about also how to sustain all of these improvements and these integration efforts that have been initiated to some degree through various grants and pilots, and thinking about how to sustain those in the longer term. So just another area just to sort of hone in on, and this is in reference to an issue brief that CHS actually published over the summer, where we explored some of the key considerations for state Medicaid agencies in terms of successfully integrating these services within Medicaid ACOs. And this issue brief really highlights the need for flexibility in ACO payment methodologies, particularly given the differences in providers' relative abilities to take on financial risk, as this might be a new area for some of them. Also mentioned in this brief, and I think an important consideration, is around the financial supports that are really necessary for these providers to secure necessary systems and infrastructure to allow for the information exchange that needs to happen to support the coordinated care. And what's also highlighted, and I think we are hearing a lot about, is really that opportunity to leverage also the newly defined roles for managed care organizations in the behavioral health arena, and how to incorporate the use of relevant measures to really align incentives across the board. And finally, some highlights around efforts that states are beginning to make to really address some of the regulatory and other barriers that Pam mentioned earlier around this integration work. So hopefully that provides you with just some background in terms of kind of the core foundational program design issues and some of the implementation considerations that we've heard about pretty consistently across the states that have been involved in our project work to date. So at this point, I would like to turn it over to our state guests, state speakers, and we'll first hear from Kara Suter, Director of Payment Reform at the Department of Vermont Health Access, who will speak to Vermont's phased approach to behavioral health integration within its shared savings program. So with that, I'll hand it off to Kara.
Great, thank you, Deborah. I think Deborah's comments will be salient for my presentation, and you'll likely hear some of the same themes she mentioned echoed in the presentation to come. Before I get into the slides, I'd like to just give you some background on our program. We launched our shared savings program on the 1st of January 2014, so we've officially been through one performance year. It is a 3-year program, and we launched the program in concert with a commercial program that was targeted at those plans operating on our state insurance exchange. The designing for the program really began sort of in late 2012 and continued through 2013, and what we really tried to achieve was building on the Medicare Shared Savings Program, which there were already in existence, some ACOs in the state participating or planning to participate, and really look at that model and in a multi-stakeholder way ask ourselves, how can we then adapt this model, which really was traditionally built around trying to get primary care and specialty and acute providers in the medical sense to come together and coordinate better across that continuum of care. How could we really adapt that model to look at the full continuum of care services provided to our Medicaid population and, frankly, a unique patient population compared to Medicare? So we knew early on that looking at how to incent integration not only with mental health and substance abuse services, but really towards all of our specialized service programs and providers was really going to be a key area of focus so that we could ensure broad-based support and participation in our program. About the same time, we also received our State Innovation Model Testing Grant from the Centers for Medicare and Medicaid Innovation, and integration of both existing programs that we had in the state and with a particular focus on mental health and substance abuse were some key goals in that grant. So around in the 2013 timeframe, all of these sort of shared goals came together. We were lucky enough to participate actually in the CHCS Learning Collaborative and learn from our fellow states about their approaches and tried to incorporate them actively into our program. So next slide, please. So what we're going to talk about today is really the result of all of those planning efforts. You'll see that in our program, we really, as the state party in a shared savings program, we felt it was, where we could be most effective was ensuring that the program design had the right elements in that we were able to set a framework that would promote integration. And at the same time, not be so prescriptive to limit innovation. And so there was a few key areas of focus that we intentionally thought through how to incent integration in terms of how we set up the financing in the program design, the governance, and particularly on our performance and quality metric side. I've included a note here on our care management. I don't go into detail about that, but I'm happy to report that actually just today we have a solid set of recommendations around care management, which include key guiding principles on integration amongst a diverse set of providers that are coming through our work groups and we hope to incorporate into our project. So not talking about that specifically today, but we are actively working on that piece as well. And you'll notice that within the program design, there's two flanking elements that we also felt were really important. One is the multi-stakeholder engagement. Our entire state innovation model testing grant, the whole governance and operations of which is really built on the premise that both public payers, commercial payers, and providers really need to come together to mutually design the path for the future. People are starting in different points, they have different perspectives, and have to weigh different influences, and that we really truly in Vermont buy into having a big tent and working through difficult issues together so to really set us up for the best chance of success with the program. And at the bottom, I mentioned provider support. It became very obvious in the early stages that without significant support in terms of infrastructure and getting some of the key elements in place to really foster care delivery, that we were almost asking an impossible task of our providers. So provider support also became a real key component to the program. Next slide, please. So this is just a snapshot of our state innovation model governance and operating structure. I think I just wanted to point out again how important that multi-stakeholder engagement can be. I will say, you know, it makes the process longer. It makes it sometimes more difficult, but I think in our at least participation in our program so to date, and really the willingness of providers to be at the table with us, we think there is some value to this. So our program is really built off, we have 7 work groups that have a specific charter and a work plan. They are chaired by members of a steering committee, and really the goal of the work groups are to be the front line in terms of identifying what the key issues that need discussion and input from a range of folks with regard to programs, in this case program design, would be we vetted them through multiple groups. Once consensus was reached on recommendations, they flow up through our steering committee, which is an appointed public-private advisory group. The steering committee then vets them, discusses them more broadly. They can at that point either push stuff back down to the work group to work on further, or they also recommend that those recommendations get sent up to a core team, which is a small decision, public-private decision-making body who then finalizes the recommendations and forms the basis of what is now our shared savings program. This is also happening obviously with additional initiatives coming through the SIM, but in fact the shared savings program was the first to go through that process. Next slide, please. So as I mentioned, there were some key elements of program design where we were really intentionally trying to promote integration. So I think one of the key hallmarks of that was our TCOC, in this case, stands for Total Cost of Care, and that is referring to the core services that we are considering the ACOs accountable for. And we landed on an approach that starts with, in year 1, the TCOC to look very much like what Medicare shared savings program costs look like, very much like the medical side of a commercial set of services. So these are things like physician services, outpatient, inpatient, hospital, durable medical equipment, laboratory, et cetera. So in year 1, we're starting with that, and 1, for consistency, but 2, again, the models were sort of developed to have those be the scopes of service. And then we built in a flexibility in years 2 and 3 to start to broaden our purview of what is considered in that total cost of care. So in year 2, we offered the ACOs an actual optional track that they could have an enhanced sharing rate if they were to take on additional cost for services that the state identified. And we'll talk a little bit more about what happened with that in the challenges and successes part of the presentation. And then in year 3, we said if we couldn't incent you to do it in year 2, then by year 3, we want you to be ready to take on a broader set of costs that the state has determined would be appropriate for this program. So that was really somewhat of an innovation, and frankly, we developed this approach in consult with some other states who are also trying to figure out a way to slowly grow and with due diligence and a thoughtful approach, move beyond the traditional medical services. Next slide, please. The next part of the program design we thought was important was to build on Medicare's 75% provider rule in their shared savings program to be very explicit that we would really want representation from a broader group of providers. So in addition to the 75% rule, we required that there be on the governing boards of our participating ACOs at least one member from the mental health and substance abuse community, as well as a post-acute provider. We also require, like Medicare, that there be a Medicaid consumer advisor on those governing boards. And in fact, I will note that our ACOs have actually evolved this to go beyond what is being required to include now an entire consumer advisory group, which is great news, and they're having a really wonderful experience with that. And they have been able to find value in having a broader array of health professionals represented on their governing boards. Next slide, please. And then I think one of the most sort of tangible ways we were able to incent integration is to ensure that in our performance and quality framework that we included mental health and substance abuse measures. In our world, in our program, we actually have 4 types of measures that are part of the program. The first are payment measures, so these are what they sound like. These are the measures that actually the ACO must meet certain quality thresholds in order to qualify for a receipt of any shared savings they may earn. We additionally have a set of reporting measures. These measures must be reported by the ACO, but their actual performance, at least in year 1, will not change the percent of payment that they can achieve, though they do have to report on those to achieve, to be rewarded with savings. We also, I'm going to skip to the blue box, which is the pending measures. So these are measures, and this is important in this domain in that there are many measures, particularly on the sort of long-term services and support side, that are not NQF, for example. NQF are nationally recognized. Many of them are kind of homegrown measures in those specialized service communities. And so we have a set of pending measures that we think are important, both the state and other stakeholders, but there was some significant challenge with incorporating them into either payment or reporting, most often because there was not widely accepted specifications or benchmark data, or actually collecting data seemed to be too administratively burdensome. So we are actively trying each year of the program to take a look at those pending measures and make some progress on them so that we can have a more robust measure set for payment and reporting in the out years. And then lastly, we have our monitoring and evaluation measures, which really are typically utilization measures. These are the things that will help us hopefully understand or be able to interpret when we're seeing savings or not, what's driving that, and where care delivery transformation is actually happening on the ground. The only other note on this slide I'll make is that really in our first year, the main difference between the payment and the reporting, frankly, is related to administrative burden. You'll find that our payment measures are typically claims-based in year 1, whereas the reporting measures are clinical-based. And so we wanted to acknowledge the burden of doing chart reviews and the costs associated with that. And it is our hope, we are in the state as part of our state innovation model, working towards what we call the VHI, which is the Health Information Exchange, whereby data will be flowing, clinical data in the future, in theory, will be flowing from EHRs directly into a repository that can be used for this purpose, but the reality is we're just not there yet. So we did have this differentiation. Next slide, please. So here's just an overview of our PY1 is our performance year 1, and I just wanted to give folks a sense of the distribution of the domains of the measures that were ultimately adopted by the work group. And as I mentioned before, the work group part of this process was really meaningful. We started with around 250 measures and had a multi-stakeholder private-public group really work through measure by measure and with some standardized criteria that everyone agreed on to get to this end. And I think another thing that doesn't come through here, we didn't show it, but we were able to have consistency with our commercial payer program with the exception of one measure in year 1, which is pretty remarkable. So we're pretty proud that we were able to align those 2 measure sets so consistently. But you can see here that there is a reasonable amount of mental health and substance abuse measures, and in fact that was, again, part of our criteria for trying to ensure that we had a robust quality framework that was incenting integration. And along with mental health and substance abuse, you can see obviously that children and adolescent measures and measures related to pregnancy are obviously important to a Medicaid program, which you would not find in the Medicare data set per se. So there are some differences there. Next slide, please. And here's just some detail about what those measures actually are. So in our performance year 1, the measures that we have, 2 of our 8 payment measures, so 25%, are actually have a mental health or substance abuse focus. I should have listed the NQF measures numbers here. I apologize. The cores are actually our internal numbers. But if anyone wants the details, these in fact are NQF certified measures as well. So the follow-up after hospitalization for mental illness, we chose to only do the 7-day. That was the consensus of the work group. And then initiation and engagement of alcohol and other drug-dependent treatment. This was also a really high priority measure and has some technical difficulties associated with it and is probably not the best measure aspirationally, but we felt it was the best available measure that we could use in year 1 with data that we could actually collect. Next slide, please. So our other measures, we have a couple in all of the categories I mentioned, the reporting, monitoring, evaluation, and a couple in pending. So depression screening and follow-up. I will note that that one is being, for year 2, proposed to be moved to payment. So for year 1, it isn't a reporting measure. And then in our pending category, we have tobacco use assessment and tobacco cessation intervention, as well as screening, brief intervention, and referral to treatment. And I'll say on that note, that is of particular importance to the state of Vermont right now, and we are really trying to work with our partners at the Department of Health and others to standardize the specifications for that measure so that we can quickly move that from pending status into reporting or payment for the future. It's felt that that is one of the most important moves we'd like to see by the end of year 3. And then one, monitoring and evaluation, the antidepressant medication management measure is included in our M&E measure set. Next slide, please. So lastly, I mentioned, the 2 flanking important parts in addition to program design was really this idea of stakeholder engagement and then provider support. So I just thought I would mention what we are doing. We are fortunate to have our state innovation model, so we've been able to make some significant HIE/HIP investments in support of integration of mental health and substance abuse. And I've just listed a few here. I won't go in detail, but in general, the focus is how do we ensure that all providers are consistently having access to good healthcare data and information, and that we are having a statewide system where we can leverage this for both care delivery transformation, but also program monitoring and oversight. And lastly, we have a provider subgrant program. So this is actually empowering our providers on the ground to help provide them seed funding to do care delivery transformation projects. And two in particular related to mental health and substance abuse are mentioned below. And I'll just say Invest EAP is our employer-based employee assistance program provider that is prominent in the state. And so we are working with them to test innovative models on the ground of health screening. Next slide, please. So I think what we've learned in our first year of experience is that, change is very slow, and we all must sort of temper our expectations about how rapidly we're going to see care delivery changing and savings being generated and quality scores improving. We are hopeful that we're going to see some change, but we are all recognizing even more that this is incremental. We continue to work through traditional mistrust among traditional sort of the medical side of the world and the long-term services and supports of mental health provider side of the world. We are doing our best to bridge those gaps, but that's the long history of that kind of divide, and it's just going to take some time. I'll say the next bullet around independent providers. So we have an interesting dynamic in that some mental health services are in fact included in our total cost of care, those that are more medical benefits like, so going to see your psychologist for counseling, those kinds of services are in, and those providers really are hesitating to jump in on these programs, and so we are working very hard in a different way to really target them and bring them in to these programs to see the value in coordinating with primary care providers and other acute providers. And then separately, separate from that, we have our specialized service providers, our community mental health clinics, which are a set of different challenges. We are seeing resistance from the provider community about increasing the number of measures and making performance targets harder, but I think that's a natural balance that comes with these types of programs and increasing accountability, and that will just be one of those things that continues to push the envelope on innovation. And then lastly, as most folks know, there is restrictions on data sharing. So in some respects, we're limited because we do strip off a number of mental health and substance abuse service claims and sharing with our ACOs. So there is a snapshot of the world that they continue to miss. Next slide. And I thought I'd end on successes. So one major success that we're very proud of is that we are seeing at a community level, really on the ground at individual community levels, this collaboration and integration is really starting to form. So both our two ACOs who are present in almost all the communities are coming together. They're now working with our existing patient-centered medical home program in the state called the Blueprint for Health. Those folks are coming together, and we're seeing more and more of the specialized service providers joining in to those local community structures to really focus on our core set of performance measures, and that's just been really starting to materialize in the last few months, and a really good sign that what we've done is making a difference. And one example we have of that is we had a learning collaborative launch just last month, and we had 94 participants in a small rural community in Vermont across every type of service provider one could imagine. So the turnout there and the enthusiasm was such that we really think we're making progress. And I think trust being built, that learning collaborative is an example of that. And our HIT, HIE infrastructure projects are moving forward. I think it's going to be a long haul, but there is a plan in place, and we're moving in that direction. And so it's exciting to think about what the world might look like when we're actually more automated and have better access to clinical data. So I think with that, I'm going to stop and hand it back over to Deborah.
Great. Thanks, Kara. Appreciate your presentation, and kudos on your very comprehensive approach as far as, particularly with your measure set, understanding that the process was an involved one with a large number of measures and several stakeholders at the table, and I think we're getting a fair number of comments from participants to that effect. So I wanted to stop here just for a couple minutes and see if we could just have a sort of brief discussion on what you've just presented, since there was a fair amount of information. And so just to sort of kick it off, and I think related to what you've been discussing around sort of relationship building among the providers and measure selection, and that balance between how prescriptive you need to be at the state level versus being flexible for providers to join the program and sort of make it their own. I think one question we're seeing is around how or what role the state really played in determining the level of sort of provider readiness to accept risk for the mental health and substance use services that you described. So I know that it's a phased approach, but I'm wondering whether you had any sort of specific criteria or approach that you use to determine, which providers are really ready and able to take on the risk for those services.
Thanks, Deborah. And I should have mentioned that when we put the program RFP out, like Medicare, we offered a two-track. One was with some risk, higher sharing rate. One was without risk, lower sharing rate. And both of our ACOs who decided to participate in our program, not surprisingly, chose the avenue that was no risk for the first 3 years. We felt in Medicaid we didn't want to push on the ACOs too hard initially to take on risk, because there was a concern that participation might be hard and to incentivize anyway. So and there were good arguments made that the Medicaid population represents unique challenges that other populations may not, and that the ACOs needed time to really learn more about management of that population, and that it hadn't been necessarily a focus for them before. So for those reasons, again, we felt we would lock them into the financing changes that would occur over time, but all of that is done with no downside risk at this point. There are active conversations, however, about the path forward beyond years 2 and 3, which we have remaining, and what happens in those out years with regard to risk. And frankly, I think the ACOs are hesitant right now to take on risk for those things that they're most comfortable with. So it's an open question about whether or not in the future they are likely to want to frankly take on risk for some of the more specialized service programs, and we are thinking through models of the future and how there may be some kind of hybrid approach or a differentiation within the TACO, for example, for different risk corridors for different types of services. So I think TBD on the answer to that, but it's certainly one of the biggest open-ended questions, and we frankly hope that our experience over the next, our experience in the first year and coming years will help inform those decisions as we get closer to the end of the program.
Great, thanks. So I think there are a number of other questions, but in the interest of time, we'll move along to the next couple of speakers, and then we'll open it up for a broader discussion across all the speakers. So thanks again, Kara. And with that, let's go ahead and turn it over to Matthew Spahn, who's a policy specialist at Minnesota's Department of Human Services, to talk about how Minnesota has encouraged the integration of behavioral health services into its Medicaid ACOs, also known as integrated health partnerships. So with that, I'll turn to Matt.
Thank you, Deborah. And good job on pronouncing the last name. That's one that most people kind of mess up. So good introduction. As Deborah mentioned, I will be providing a quick overview of the Minnesota Medicaid ACO, or the Integrated Health Partnerships, or IHP as we call it for short, with some focus on how we address or don't address those behavioral health services and integrating them into the model. I am going to keep things fairly brief, though, as I think really the most interesting thing for Minnesota today is going to be out of Mary's portion of the discussion. So I want to just kind of set the ground for the IHPs broadly, but really a lot of the details I think that are going to be the most interest to the crowd is from Mary and Southern Prairie. That said, when designing the integrated health partnerships or the IHP demonstration, we really wanted to focus on the what rather than the how. We didn't want to be terribly prescriptive, but more describing the goals of of better health at lower costs and allow for very broad flexibility across our participating providers. I think that's similar across other states that are implementing Medicaid ACOs, but of course, certainly in Minnesota that was a big part of it. Similar to these other ACO models, including as CARE described in Vermont, we did need to establish a core framework of accountability, if you will, which includes the accountability for your attributed population or attributed patients' total cost of care, and that total cost of care, or TCOC, needed to include a broad spectrum of services for the provider to be responsible for, but also an inclusion of a robust, wide-view quality measurement system that tried to focus more on outcomes rather than processes alone, and cut across many different clinical areas. Around this core, we encourage our individual IHPs to prioritize their efforts to sort of identify who their target populations are, the best way for them to develop care management and care delivery systems, and really the best way to meet our demonstration's overall goals within our broader framework. And so with that, we do encourage the IHPs to identify areas outside of our core services that they may be uniquely able to take responsibility for. For example, that may include additional services and total cost of care calculation, or it could be different or additional quality measurements, quality metrics that their specific target population, that just makes more sense for their target population. And we just began the third year of our demonstration last month, and we have 15 groups participating as IHPs. And I would say that probably because of our model's flexibility and the various needs across the state, our 15 IHPs vary in sometimes pretty wide key areas. That could include, like I mentioned, the care delivery and care management approaches, their governance structures, the partnerships both with community members and providers within their area that they've developed, how they're going about data sharing and data analytics, and then of course the characteristics of their target populations. So relevant to this webinar, one of the key areas that we are beginning to see more diversity in is the integration of behavioral health services, behavioral health providers into their broader IHP model. In what I would describe as our core services, I would say that our behavioral health services, behavioral health overall, is maybe partially integrated. And I say that to mean that we do include some basic mental health and chemical dependency services within our total cost of care calculation, but we exclude what's probably the most expensive behavioral health area care, such as the inpatient intensive care services and the like. What this leads to is that we include anywhere from maybe about a quarter to about a half of the cost of behavioral health services that an IHP's attributed population accrues actually being attributed back to the IHP and actually being accountable in that total cost of care calculation. And I think we see this as really leaving quite a bit of opportunity on the table for IHPs to explore and develop methods to take on. We additionally, as I mentioned in the quality measurement side, we do include a depression remission measure, depression remission after 6 months, within our core quality measurement system. However, this measure we have heard isn't necessarily appropriate for all the target populations that an IHP serves, and it doesn't necessarily provide that wider behavioral health view. So it's certainly an area that I know we're interested in looking at additional opportunities within. But importantly, and what I think has really helped and where we see the opportunity for integrating behavioral health is through provision of clinical data and reports across nearly all of the services that an IHP, their attributed population, may receive. and that's whether the service is part of the included within the total cost of care or excluded. We still want to provide them with as much of that data as possible, and that does include most of the behavioral health services. As Kara mentioned in describing Vermont, there are certain chemical dependency services that just legally we're unable to share, but generally speaking and broadly, we do try to provide as much of the data as we legally can to the IHPs, which we think really allows them to identify what their population's needs are, where the level of that care is across various services, including behavioral health, identifying where that care is taking place, which providers are currently serving their attributed populations in their area. And all of these pieces can really allow them to see where those opportunities are to really integrate behavioral health in a more effective way. And we have heard from IHPs that that's something that they've begun doing, is to identify through the use of the data where those opportunities for coordination with behavioral health care in their area, partnerships with providers, community members, may be within, that are already working with their population and within their area. And again, since our model allows for that pretty broad flexibility, the IHPs that are sort of most uniquely positioned to take on behavioral health services that have identified those various opportunities can add them to the model in a number of different ways, again, including the total cost of care services that are within the included, and they certainly could also suggest additional measures in the type. So with that, I do want to say I think Southern Prairie Community Care, which Mary is going to be talking about next, is perhaps one of the best examples of the flexibility that we've found within our IHP project. And that's both in terms of integrating the behavioral health services, but also more broadly in their approach to partnerships, community involvement, and data analytics. And I certainly don't want to steal any of her thunder, so I think with that I'm going to hand things back so that we can really get to what I think is going to be the more interesting Minnesota section of this webinar to Mary Fisher from Southern Prairie Community Care.
Thanks, Matt. This is Deborah. Just wanted to say thanks. That was helpful context regarding Minnesota's approach. So with that, I'd like to hand it off to Mary Fisher, who's the Executive Director of one of Minnesota's IHPs, as Matt described, the Southern Prairie Community Care, and she'll discuss how the state's program design structure is being implemented at the provider level in Minnesota. So
yes,
Mary?
thank you very much. First of all, I'd like to thank Matt and the Minnesota Department of Human Services for what really has developed into a true partnership, and it's the department's flexibility that has allowed us to become very creative in terms of what this virtual ACO that's in a rural environment is looking like. So it's been very affirming for me to listen to Kara articulate some of the challenges and the opportunities. I would echo many of the same. And I think another point that we probably will have only a very little bit of time to get to today is Southern Prairie Community Care considers the Integrated Health Partnership as a template or a bit of a beta test for our group in terms of really fine-tuning core principles. And our plan is to expand beyond the Medicaid population through a significant partnership with one of our majority health plans. And I don't know if I'll have a lot of time to talk about that today, but hopefully a little. So the Integrated Health Partnership, in Southern Prairie's opinion, is the first phase of a multi-phase, multi-year project that really will take all of these principles and apply them not only to Medicaid, but eventually to Medicare recipients, commercial recipients, et cetera, until all of our residents are being cared for in a very locally driven way. So again, I'm going to be challenged to stay focused enough to only take my 20 minutes here. So I think you'll hear that many of the themes that were previously shared will also come through in my presentation. And maybe I will just leave it at that for right now. So we can go to the next slide. I thought it would be interesting for the group to see Minnesota at a glance. And this map was created in our early phase, and it does not include the 15 IHPs that Matt was referencing, but it does include, from a structure perspective and a foundational perspective, the amount of county collaboration related to healthcare reform that has occurred or is occurring in the state of Minnesota. And I thought it would be interesting for people to get a little bit of a lay of the land in terms of what's happening. So if we go back to the mid-90s, it was a very strong movement in Minnesota that county collaborations became focused on county-based purchasing, or the focus would be when county collaborations decided to develop a health plan focused on local coordination of care. And those examples, again, going back to the mid-90s, would be the Prime West Health System, South Country Health Alliance, and IM Care. Now, I feel that the county-based purchasing movement is an important part of Southern Prairie's history because we actually began as an entity that was interested in the potential of becoming a county-based purchasing entity or a county-based health plan. But at that time, the governor was placing limitations on any expansion in those program areas. So our planning actually began in 2006 with an early focus on the potential of becoming a county-based health plan. With a change in governors or change in administration in 2010, we began talking more with the state of Minnesota about the potential of becoming this new idea of an ACO. So that was really where our planning efforts focused, and we began full-time planning in 2012. And entered into negotiations with the Department of Human Services around this integrated health partnership concept in mid to late 2013. So I just thought that history would be interesting for folks in terms of what Minnesota has done. I should also mention that the Arrowhead Health Alliance is a second project that is considering the possibility of ACO-type models or integrated health partnerships, and I would describe them as a little bit behind Southern Prairie in planning and potential implementation. So in summary, there's really been quite a bit of county-driven health reform in the state of Minnesota over the past couple of decades. Next slide. So what is Southern Prairie? Southern Prairie is described as a virtual ACO network. We've got 27 provider members, including the clinics and hospitals in our area, with the exception of one hospital system. So I like to say that we have 100% participation with the exception of one health system. We've got all of our public health entities, our mental health centers, and all of our area human service agencies involved in our virtual ACO. And we have always felt that the strength of our approach is really that we're able to quickly organize. We are governed by county commissioners, and I'll get more into that in a little bit. So county commissioners have played an important role in the origination of Southern Prairie. They are our governance structure, and they also have a very important liaison role. If you consider that county commissioners typically, at least in our area, are the governing officials for some of our hospitals and clinics, for all of our mental health centers, our human service entities, public health, corrections, community action agencies, et cetera. So the county commissioners are in a very unique position, again, helping us to quickly educate and quickly mobilize around this multi-sector approach. Okay, the next slide, please. Southern Prairie Partners, Southern Prairie Community Care Partners, obviously we're very involved with the Minnesota Department of Human Services, and frankly, I cannot say enough about the amount of support that we have gotten from the Commissioner of Human Services and the staff that she has there, not only as an official integrated health partnership, but all the planning and coordination that went into our efforts prior to becoming an integrated health partnership. So we are in the midst of a 3-year Medicaid demonstration, which will take us through 2016. We're just beginning our second year of the project, and year 2 includes mental health costs in our total cost of care. And I will mention to folks that really our original intention was to potentially begin the project with the inclusion of mental health costs within our total cost of care. Again, our public sector folks are by far our most supportive. They were, along with the county commissioners, the originators of the concept and the champions in bringing it forward. But we decided that we would use our first year as a way to get acclimated to this total cost of care environment, get a lay of the land, understand the process better. So everyone had a desire to begin in year one and was definitely ready to go at the beginning of year two. Through the SIM project, we also have a significant partnership with the Minnesota Department of Health. They've been very involved in our health information exchange activities. And as I said, we've been very fortunate to receive state innovation model dollars to fund a significant portion of our health information exchange. We were just awarded a 2-year grant. We were identified as one of Minnesota's accountable communities for health and received funding for a 2-year diabetes initiative, which began in January of this year. And sadly, I wrote these slides a while ago. The learning community, we applied to also be one of Minnesota's learning communities, and we actually just found out yesterday that we were not awarded that. So I should not have that on the slide, but we have felt very good about the opportunities that the State Innovation Model Programming has presented for Southern Prairie, and it's really allowed us to connect with folks in not only locally but across the state related to the type of reform that we're working on. Another piece that's very unique about our project, and I'll get into this more as part of another slide, I would say that the political environment in Minnesota was very helpful to Southern Prairie Community Care in the fact that our region was up for procurement for public programs just prior, well actually would have been up this year for procurement while we were in the midst of going live with our integrated health partnership. Blue Cross Blue Shield has about 85% of our market across all of the sectors of insurance and saw Southern Prairie Community Care as a wonderful mechanism for them to improve their performance around quality measures, improve their relationships with county health and human service officials, enhance their ability to integrate mental health services or care needs with primary care. So we were very fortunate at just before the beginning of our integrated health partnership that we were able to construct a 3-year financial arrangement with Blue Cross Blue Shield. So Blue Cross Blue Shield is actually paying for Southern Prairie's operations through the demonstration project. And as any of you know who have done work like this, it can be a very expensive process in terms of the level of staffing that's needed, the planning that needs to go on, the type of consultation that you need. So we've been very thankful that Blue Cross Blue Shield has identified themselves as a significant partner. The landscape for our integrated health partnership is that Blue Cross Blue Shield, again, has about 85% of our network, and our second health plan that's involved in Medicaid in our 12 counties is UCare, with about 15% of the population, roughly speaking. So all very unique components of the model. Let's go on to the next slide. I know this is a very busy slide, but I think it is an awesome illustration, and this was one of our very first graphics that was created. So I'll start at the top with the relationship that we have with the Minnesota Department of Human Services in terms of the integrated health partnership. That relationship is directly with Southern Prairie Community Care's Joint Powers Board, and our Joint Powers Board, this ACO, is governed by 12 county commissioners, one from each of our 12 member counties, along with an alternate from each of those counties. So 24 county commissioners that have been very actively involved in planning efforts since 2006, and I will also note, as a very important part of our story, some of our funding decisions or governance decisions do need to go back to the county boards of origin. So I like to say that we have had the potential of up to 60 county commissioners having alignment about the importance of this type of health reform happening in Southwest Minnesota. I just think that's a really powerful statement, and we've had alignment, again, going back to the beginning of our planning efforts, which would be 2006. The County Joint Powers Board works closely with what we describe as our rural community care system, which in essence is our provider network, our multi-sector provider network. So it includes, again, our 27 members, our hospitals and clinics, mental health centers, human services, public health, and other entities that are involved in providing care. It was very important to our county officials that they had an opportunity for what they would describe as frontline feedback related to some of the important decisions that they were needing to make. And part of that evolved into the development of a 501c3, which is called the Southern Prairie Center for Community Health Improvement. The governing structure of that board includes county commissioners, it includes administrative staff and frontline staff, as well as providers of service. So that board is has more of a frontline focus and is able to provide really solid recommendations to our governance structure around health information exchange, appropriate use of clinical information, protocols and processes that we want to adopt overall. So our governance structure is our public officials, but then we work very, very closely with our 501c3 board that is represented by our provider network in terms of its governance structure. So those two boards are meant to work in tandem in terms of the important things to have in mind from a visionary or governance standpoint and making sure that we have really consistent frontline information as part of those decisions. Now I will go over to where it says PMAP plan on the right-hand side, and you can see, as I've mentioned, UCare and Blue Cross Blue Shield. Our model is slightly different than the county-based purchasing models that I referenced earlier, in that the health plans that are involved in our 12 counties continue to provide all the health plan functions that are typical. So I would describe what UCare and Blue Cross Blue Shield does for Southern Prairie as more of the back-end functions of this entire process. And Southern Prairie's efforts are more focused on front-end service delivery in terms of mobilizing multi-sector teams, having a very integrated approach to community care, et cetera. So that's our model in a very brief nutshell. It's definitely unique, and it's been working very well. I'll talk more about breaking that down as we move through the presentation. We can go to the next slide, please. Just a little bit of a snapshot of the shared savings formula that is part of our integrated health partnership. This process took us a very long period of time, was consensus driven, and many months of work group processes, many meetings to come to the consensus of how we would distribute our shared savings as part of the integrated health partnership. So you can see that our primary care network, sort of the drivers of the bus, will receive 60% of the dollars that are saved. Something that's very unique about our model, we actually have a significant share of the savings going back to our area hospitals. Not that we think that the dollar amount within this project equals sustainability for our hospitals, but we thought it was a very important piece in keeping our small hospitals at the table and keeping them engaged. Obviously, the low-hanging fruit, at least in the initial phases of organizing, is less use of the emergency room and less use of the hospital. And the best way that we could develop to keep our hospitals at the table was to have some of that shared savings be going back to them. I would say another sort of burning platform in terms of all the work groups and processes we have been involved in, always with the future in mind, is what does healthcare in Southwest Minnesota look like in the future? Not only are we focused on opportunities within this integrated health partnership, but we've always got our mind's eye on what Southwest Minnesota will look like as reform continues and our critical access hospitals continue to be challenged by this environment. So whatever we can do to foster a series of discussions to help our critical access hospitals, which frankly in our area, all of our hospitals are critical access except for one. What can we do to help our hospitals navigate this shaky bridge in the midst of reform? I think another important part of our story is that our mental health centers and our social service agencies are actually only receiving a small portion of the shared savings to come back into their focus. So again, those two entities very invested, very involved, but don't see the shared savings as the primary motivator for them. It's really about the opportunity to integrate care in a way that has not happened before. And I've already mentioned the importance of keeping the medical community at the table, but I really have learned a lesson in terms of continuous persuasion and collaboration, because the one thing that we have is our collaboration focus and persuasion. We don't have funding sources sort of following the efforts that we're trying to achieve, at least not at this point. So it's really been very focused on that continuous persuasion and buy-in, not related to the here and now in terms of payment, but collectively planning for the future. Definite lesson in all of this development. We can go on to the next slide. This graphic illustrates what I would describe as the 4 pillars of Southern Prairie Community Care. So we are a 3-year demonstration project, at least for right now, in terms of our integrated health partnership with plans to expand, as I mentioned. But as we go through these pillars, I think there's some important things to note. If you look at the state of Minnesota that is on your upper right, an integrated, locally driven model of care and support. The focus here is on multi-sector care teams organized around all the concerns related to the superutilizer. So using our DHS claims information that Matt referenced earlier to organize these multi-sector teams and assure that everyone involved with a patient is at the table when that care plan is being developed. And this has been challenging because I think if you talk to someone who's providing care coordination right now and you begin to have a conversation about the importance of medically integrated care coordination, everyone already thinks that they're providing a level of care coordination that is fully integrated with the medical community. So one of our biggest challenges has been education around what does that truly integrated medical model mean in terms of achieving the kind of ACO-like results that we're looking for, such as fewer hospital days, less use of the emergency room, et cetera. So the development of these care teams has been quite an undertaking. I wouldn't say it was underestimated, but I would say that it is living up to the fact that it takes lots of time and attention. The second pillar that I would like to talk about is on the lower right, individualized care through a comprehensive health record. This references the fact that Southern Prairie was an eHealth grantee through the SIM process, and we're in the process of implementing a health information exchange across our entire network, so including all the sectors that were mentioned, and we're also working on becoming certified as a health information organization, which relates more to the consensus building and the governance process around the sharing of information. And that's a recent development. We began working on our certification as an HIO probably late summer of this year. I'd be happy to go into more detail about any of those if you would like. The third pillar, improved population health in our 12-county region. Definitely a big focus for Southern Prairie, and again, we're really proud to say that we have been a SIM awardee. We are beginning our first population health project that began in January, so just last month, and we are focused on a 12-county diabetes initiative, total population that's focused on the importance of early identification, of pre-diabetes and community-based settings to accomplish the screenings where screenings have not typically occurred. Other community-based events, maybe piggybacking on public health activities, setting up days within our area mental health centers, and from a strategy perspective, developing methods or ways to reach into populations in terms of diabetes prevention, the folks that maybe are less able to adhere to traditional diabetes prevention type of classroom education, et cetera. So we will be challenged to screen in places where screenings are not typically available and developing methods of intervention for folks who are a little more challenged with compliance related to that. The last pillar that I wanted to talk about is a pillar of health equity and access to care and support for all. The focus here is we're an area that is actually very culturally diverse, and that's a fairly new phenomenon in Southwest Minnesota, but lots of opportunity for improvements in our ability to integrate across cultures. We'll be taking a look at various economic groups and opportunities to assure health equity there. And we are always challenged by the differences between the rural and the urban settings in terms of equity in care. Again, a particular focus also on health equity for folks in our area that have disabilities or impairments of some other kind. I will echo the approach, and I did not spell these out for you, but we have a multi-sector approach, a work group process for each of these pillars to assure provider participation in each of those and consumer involvement in each of those. So I would describe these pillars as also very specific work tracks driven by a work group process that involves the provider network and also the consumers in each of these areas. All right, next slide. I need to keep moving here. All right, our integrated community care. We have developed a toolkit very specific with guiding principles, and maybe in summary what I would say related to the integrated community care is that we began this process with a very sincere desire to build this community care model from the ground up. And what we learned was our systems, multi-sector, every system included, was so stressed in terms of time and resources that the desire was there, the buy-in was there, but we really found ourselves coming forward with a very prescriptive method for organizing the different sectors. So that Southern Prairie did the heavy lifting, very prescriptive about what the model and workflows should look like, and then our provider network is able to tweak or provide feedback. But again, education around using those DHS data sources, education across sectors around high-risk folks, complex conditions, medical, mental health, emotional, family circumstances, and other social determinants. And it's been a very effective exercise. I think that having access to that type of medical information for our more community-based folks has been an eye-opener, just in terms of being aware of things and engaging in prevention and early intervention in a way that's very different when you're coordinating a community plan without the medically integrated information. So it's just been a wonderful process. I would say lessons learned in regard to this integrated community care piece. We're a small area, and we pride ourselves in the fact that everyone knows each other, but it's been a definite learning. We underestimated the need for the foundational work. We underestimated how strong the silos were, even in Southwest Minnesota, so lots of foundational work in year one. I think I would just echo all the comments related to primary care in the earlier presentations. If we had it to do over again, we would have even involved primary care at a higher level than we did in our planning phases, because we find it takes more time, and we're having to do more catch-up than maybe we would have had to if we would have had an even more deliberate and concentrated effort around our primary care network. And they were involved, but I think we underestimated some of the challenges of engagement there. Next slide. All right, I just wanted to point out some of the very specific opportunities that we've had to partner with the Minnesota Department of Human Services. Minnesota DHS worked closely with us and the Bush Foundation on what we would describe as a system redesign. That's very focused on placing professionals in the field at various facilities, so they are embedded in member facilities, focusing their efforts on integration and coordination of care. So for the purposes of the mental health discussion, we have placed RNs in each of our mental health centers as our integration coordinators, and that was the mental health center's choice because they felt that that was the expertise or the discipline that they could learn the most from in terms of a system redesign. And we've got similar placements or similar professionals placed in, for example, we've got a longtime county mental health and chemical dependency worker placed in one of our primary care clinics with the purpose of bringing that discipline or approach to the primary care world. And I won't spend a lot of time on that, but the system redesign that we're working on in terms of care coordination and figuring out new methods for cross-pollinating, so to speak, has been a big part of our work in year one. We're working closely with the University of Minnesota around an expansion of the medication therapy management network. We're very focused on training our groups around the opportunities related to polypharmacy. Our pharmacy network will also be connecting to our health information exchange in a view-only capacity, again, focused on increased collaboration with the pharmacy network and expanding opportunities for our most vulnerable folks to have that one-on-one pharmacy consultation. We do see it also as an opportunity to build a bridge between our mental health and primary care providers around the importance of managing those medications and the opportunities within that. I've already talked about the inclusion of mental health costs in our year 2 total cost of care, and again, I can't say enough about the support of our creativity that the Minnesota Department of Human Services has had. We have had to make specific revisions to our data sharing agreement given our provider network's multi-sector nature, so we saw lots of flexibility there with the Minnesota Department of Human Services, allowing us to do some sharing based on the uniqueness of our model, allowing things to move more quickly in terms of the multi-sector team design. And we continue to work with the Minnesota Department of Human Services to find a way to interface the Minnesota Social Service Information System into the Southern Prairie HIE. And we were having a discussion last week that related to finance and data analytics, and 2 of our primary care providers were very outspoken. If they could name 1 or 2 things that they see as a critical component in their ability to get to the next level of integrated care, obviously it's important that you're exchanging information with your neighboring medical organizations, but they actually cited the importance of the mental health interface within the Health Information Exchange and the social service interface / public health in terms of the value that they see in the early implementation of the Health Information Exchange. Again, I talked about social services having access to medical claims information that they have not had before, and the converse to that is sort of the primary care community's excitement around information that they have previously not had access to. So I think that's worth mentioning too. All right, next slide. Oh gosh, let's see. I'd like to make a few points maybe before, or just a couple of points. The challenges that were presented earlier related to Vermont, I would agree with those. I would say that the other thing that we are challenged with is we continue to try to create a collective burning platform, convincing our frontline folks in the importance of engagement around reform efforts now. in the here and now versus something that can be dealt with when the system forces the change. You know, when you do not have payment sources tied to this type of change, you're challenged again with that convincing, collaborating, et cetera. And so we have continued to try to create a burning platform for the frontline folks in terms of it really being in their best interest to do as much standardizing of these processes as possible in an effort to get ahead of the way the system is changing in Minnesota and beyond Minnesota. So that has been one of our challenges, maybe one that has not been highlighted in earlier presentations. When I think about successes, just very briefly, the IHP project is definitely considered an early success, and again, as a platform or a bit of a beta test for an eye on the future and what we would describe as our plans to continue to expand with the health plan partnerships that we have across every population until the citizens in our 12 counties are served by this locally driven model of care. I'm just going to stop. Right there. Sorry.
Great. Thank you, Mary. Really appreciate your comprehensive presentation. Unfortunately, we don't have a whole lot of time remaining, but I think it is very helpful to hear sort of the provider perspective of the work and really how the decisions at the state level are playing out at the ground level and how your integration efforts are really fitting in with the broader population health vision. So I think at this point, you know, we've had several questions come in around sort of the care integration models that are being supported both at the state and provider level, some questions around referrals and coordination and the financing shared savings approach. And so with that, given that we're short on time, I'll just say that we will plan to share the slides after this webinar as well as the recording for those who couldn't join. And I just want to take the last minute or so to just thank you all, Kara, Matt, Mary, and again our thanks to Pam Riley and the Commonwealth Fund for sharing your time and your insights with us here at the Center for Healthcare Strategies. And of course, thank you to all our participants for your questions, and apologies for not being able to get to all of them. And I would just say that you all should be, please refer to our CHCS website for, we have several resources related to Medicaid ACOs and behavioral health integration, including a brief that's coming out later this week around state efforts to support social service delivery through Medicaid ACOs. So with that, we will adjourn for today and look forward to future opportunities to convene you all to discuss delivery system and payment reform efforts. If you all could please just remain online for just a quick evaluation of the webinar, that would be great. Thank you.